Regarding the cerebral palsy, it is due to a non-progressive lesion in the insult to the brain. While the insult to the brain or neuromotor system is non-progressive, the musculoskeletal symptoms are progressive. That's why we have different spectrum of diseases. Regarding the cerebral palsy, these are continuum of different type of lesions which can happen. Regarding this can be in a prenatal, perinatal, or postnatal. In the prenatal, it can be due to compromise in the placenta due to the smoking or alcohol, torch infection which consists of toxoplasmosis, rubella, cytomegalovirus, and herpes simplex virus. Perinatal, while difficult labor, hypoxia, or anoxia, or postbirth due to head injury or any infections, or difficult delivery. Regarding assessment of the patient, these patients need to be assessed by a multidisciplinary assessment. Regarding the examination, when I see a child, I need to assess for history. In history, I want to exclude the to I want to know the symptoms, developmental milestones, and exclude the causes which I underlined above. Regarding the history, I would like to know the milestones in which I would address the child sitting up till age of 10 months, standing up till a year, 1 year, walking up till 18 months, and jumping till the age of 4. I will also want to assess for primitive reflexes and the mature reflexes. I need to assess the deformities in the upper limb, which can be shoulder adduction, flexion deformity of the elbow, thumb in palm, head control, spine exclude scoliosis, any bulbar involvement, hip flexion and adduction contracture, knee flexion contracture, and foot deformities like equinus, equinovarus, or equinovalgus deformities. Regarding the assessment, it can be a different types of cerebral palsy, which can be classified with respect to type of palsy and extent of palsy and extent of function. In the type of palsy, the physiological pattern is either spastic, athetotic, chorea, hyperreflexia, or a mixed form, or dyskinesia. Spastic means time-dependent change in the rate-dependent change in the tone of the patient. Rigidity is time-independent change. This happens due to cerebral lesions, and we'll have contractures because of underlying muscles involvement. Chorea is random movements while not moving. It's wriggling movements which reduces when the patient starts moving the limb. Athetoid is basal ganglia involvement with the balance issues. Hyperreflexia is and mixed sort of patterns. Regarding location, it can be a monoplegia, diaplegia, hemiplegia, paraplegia, and quadriplegia. Regarding the Functions, it's a gross motor functions assessment. Number one is a patient who is ambulant and active and can do activities of daily living without any support. Grade 2 is the one which needs assistance for some difficult movements like walking stairs. Grade 3 are those which can use walking aids. Grade 4 are those which can have head function and can use electrical chair. And grade 5 are those which needs, you are totally dependent and does not have any head control. When I see a patient, I need to examine this patient. Regarding the hip has adduction contracture. When I see the when I examine the patient, I need to examine it from tip to toe. Regarding the spine, I will exclude scoliosis. Ask the patient to sit and check if the scoliosis is corrected and to see if there is any pelvic obliquity. Check for the flexure deformity of the hip by doing Thomas test. Prone the patient and check for the rectus contracture by Duncan's alley test. In this, I position the patient prone and try to flex the knee. If the hip lifts up, this means there is a rectus femoris contracture. Similarly, I will, in extension, abduct the hip in prone position and will check after flexion of the knee and check if there is improved abduction, which shows a flex gracilis contracture. After Thomas test, I want to see the range of motion of the hip. I want to check for limb length discrepancy. Check the popliteal angle by lifting the hip and flexing 90 degree, and then checking the angle which is subtended between the knee and as the thigh and the leg. Check if it's correctable. For the foot, I want to assess the patient with respect to any contracture. I need to examine the patient with respect to gait to exclude type of gait. It can be spastic gait, hands-on knee gait, Tredelenburg gait, or a crouch gait. Crouch gait is a gait which there is a flexion contracture of the knee as well as a dorsiflexion of the foot. Regarding the plan of intervention, it is a multidisciplinary approach. I need to examine a team approach which consists of orthotics, physiotherapist, surgeon, and pediatrician. The type of surgical intervention which is possible is for the shoulder, there is adduction contracture for which a possibility of subscapularis release, physiotherapy, or osteotomy. For flexion contracture, the possibility is to have a bicep release or brachialis release. For a pronated position of the forearm, it can possibly to have pronator release. Thumb and palm deformity can be by adductor tenotomy of the thumb muscles, as well as the release of the crease. Regarding the spine, it's a progressive C sort of curve, which can be offered operative intervention in the form of fixation, as brace is not effective. For the hips, there is adduction contracture for which X-ray can be expedited. If Rimmer index is more than 30 degrees, then a 6 months follow-up is required. The surgical intervention, it depends on the type of contracture, and if it's need a surgical release. X-ray will identify how much is the dislocation. Unilateral dislocation can be offered operative intervention. Bilateral non-painful dislocation does not need any operative intervention. Operative intervention consists of various derotation osteotomy, release of adductor muscles, as well as the rotational osteotomy. Pelvic osteotomies are always indicated, are sometimes indicated, along with femoral shortening osteotomy. Regarding the knee flexion contracture, I would prefer to continue with a serial clasting. Once the good range of motion good flexion is achieved, I can proceed with other operative interventions. If flexion contract if the extension contraction is not improved, I can proceed with operative intervention in the form of gastrocnemius release. It can be a proximal release or distal release of gastrocnemius of the rectus femoris muscle release, quads release. Regarding the foot, it's if there is a equinus contracture, we can do tentative Achilles release, plantar fascia release, as well as deformity, which is a correction procedure as indicated. At the higher age, if there is a single foot involvement, we can go for arthrodesis. There are two types of concept regarding surgical intervention. One is birthday operative intervention and single event multiple level surgery, SEMLS. Nowadays, it's indicated to have a single event multiple level surgery instead of surgery every event. A quite common scenario is to have equinus contracture of the foot along with flexion contracture of the knee with low power of gastrocnemius, as well as quads muscle, as well as hamstring muscles. In such situation, lengthening of the foot, gastrocnemius, lengthening of the tendo-Achilles muscle can cause crouch gait and increase the deformity. If the gait is with a quadricep weakness, then ground direction foot orthosis can be indicated. In such situation, application of cast and assessment with the cast to see the compliance can be noted, and if it's effective, operative intervention should be proceed. There are other type of operative interventions for spasticity that can be Botox injection or a selective rhizotomy. A clear approach should be giving a local anesthesia around that area and to see the effect of the lignocaine. If it does improve the symptoms, then we can proceed with Botox injection. Botox is basically will stop the acetylcholine release and reduce the spasticity. Baclofen pumps are also involved. Baclofen pump are GABA agonists, which reduce the excitatory muscles. Selective rhizotomy is also indicated in certain situations, but is now out of fashion.